Welcome and bienvenue to the HWell Epic Conference of 2022. I'm Josephine McMurray, HWell's Associate Scientific Director and an Associate Professor at the Lazaridis School of Business at Wilfrid Laurier University. And I am absolutely delighted to announce that we have a record-breaking number of registrants for today's session. So well done and welcome. Although we are meeting virtually again this year, I would like to acknowledge the Indigenous peoples of all the lands our speakers inhabit. I do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. I encourage you to reflect on the land on which you're located and to consider your relationships to the land and to the people who are the traditional keepers of that land and to become allies in that important work. The HWell Network Office operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And we recognize the current treaty holders, the Mississauga of the Credit First Nation. This land remains home to many diverse nations, Inuit and Métis peoples, and is subject to the Dish with One Spoon wampum, which is an agreement to peaceably share and care for the Great Lakes region. I'm grateful to have this opportunity to work on the land today and acknowledge our accountability and responsibility to further the reconciliation process. HWell is committed to fostering equitable and inclusive practices across all its programs and explicitly welcomes and strives to incorporate Indigenous ways of knowing and being throughout our research and education programs. HWell Canada's Technology and Aging Network was launched in 2015 to address a very real need, the need for better solutions to address the challenges of aging well in Canada. Older adults are a rapidly growing segment of the Canadian population. There are more people over the age of 65 than children under 15 now. And in fact, population estimates indicate that 1 out of every 4 individuals will be 65 or older by 2030. This is a massive demographic shift, and our health and social services or businesses and products must change to accommodate both the existing and emerging needs of older populations and those who care for them. As a network, HWell brings together researchers, students, government, industry, and most importantly, older adults and caregivers who we welcome today to create and implement technologies and technology-based services and policies to increase well-being and to improve quality of life. Since that early 2015 start, we've grown to support over 250 researchers. We've trained over 1,200 trainees and research staff. We've engaged with over 500 partners and over 5,000 older adults and caregivers. And that doesn't include the incredible group of networks that we have also connected with that aren't included in that count. Our researchers have created over 118 solutions, including technologies, services, and policies. And we support almost 60 startups, many of which have grown from this network-supported research, and many of which were founded and run by our network trainees. As a network, we believe in making real-world positive impact, and we believe that this is best achieved by pursuing collaborative impact. Only by working together across disciplines, sectors, regions, provinces, and yes, by working closely with all our stakeholders and co-creating with them, can we truly generate better health outcomes and make real the HWell vision. That vision is to have Canada's leadership in technology and aging benefit the world. So the EPIC conference, now in its 3rd year, was also born out of a need, a pandemic-driven need, as it turns out, to create a new virtual and accessible space in which our trainees and stakeholders could share their stories, learn about the innovative work being done across Canada, and network with colleagues around the world. We're so proud to report that the EPIC conference is the largest virtual conference in the age tech space, We convene 1,000 delegates each year from over 21 countries across 6 continents. Pretty impressive. The EPIC Conference's continued success is testament to the persistent need we see to continue to build and scale the age tech sector in Canada and worldwide. In this 3rd year, you'll see a few changes to the EPIC Conference. The program and the structure has been tweaked. We've dropped the Twitter presentation stream, though we encourage you to live tweet presentations using the hashtag AWEPIC 2022. And we've shortened the conference duration from a full month down to 2 weeks. I assure you, however, that our program remains rich, and we invite you to join us over the next 2 weeks, from May 30th to June 10th, for a feast of talent. This includes 8 panels of research presentations by trainees and stakeholders that emphasize how we're moving the dial in this sector. These research presentations are organized across the 8 age-well challenge areas. So these are the 8 complex problem areas that we identified as spaces that demand age tech innovation and the deployment of those real-world solutions. We have 3 partner-driven panels and workshops on topics as diverse as the research policy dynamic, the academic publishing opportunities in age tech, and equity in aging. We have 4 French language partner-led sessions, including a virtual robotics lab tour, looking forward to that, and presentations on rehabilitation, transdisciplinary working, and living laboratories. Last but not least, an epic networking event that is not to be missed, hosted by Jennifer Polk. It's an opportunity to meet with colleagues from around the world. So I encourage you to check out all the AgeWell EPIC Conference webpage for the conference program and the registration information for each one of the sessions. All EPIC Conferences sessions are free of charge. There's no money changing hands here, and everyone is welcome to join in the conversation, ask questions, challenge assumptions, and learn about the innovations that can make a difference in your life or perhaps in the life of someone you hold dear. So as we come together to collaborate, connect, foster an inclusive community, this 10-day virtual conference where we recognize and share responsibility for creating and holding that environment as beneficial for all. We value the participation of each member of the community, and we try to deliver an enjoyable and fulfilling experience. EPIC Conference participants are asked to conduct themselves with integrity, with courtesy and respect for others, and maintain the highest level of professionalism at all event sessions. All attendees, speakers, organizers, partners, sponsors, and staff are required to observe our code of conduct, which you may read on the EPIC Conference website. I'd really like to thank the organizers of this event. Sam and Alison are amazing. Our AgeWell partners, stakeholders, especially our older adults and caregivers, you're critical to the success of this conference. So we'd also like to thank, of course, the AgeWell students, the postdoctoral fellows, the research staff, and ECRs who are here to share their research with us as well. So from our end, the future of age tech has never been brighter. And with no further ado, I'm going to now turn things over to Session Chair Dr. Jeffrey Jutai from the University of Ottawa to introduce our first session on the topic of supportive homes and communities. So over to you, Jeff.
Okay, thank you very much. That was a lovely introduction. And I want to thank as well the organizers and Alison and Sam in particular for once again inviting me to do the honor of chairing this session, this challenge area session today on supportive homes and communities. And what I'd like to do just to begin is to give you a brief introduction to the 3 sets of presentations and presenters that you're going to hear from today. And then I've got a few programming notes that I want to share with you. So let me just begin by telling you that our first set of presenters will be Dr. Vikki Kamisar. Vikki is an assistant professor of mechanical engineering with the School of Engineering at the University of British Columbia, the Okanagan campus. And Vicki's interested in her research on understanding how the design of the world around us affects the safety and independence of mobility and other activities of daily living, and the risk for falls and fall-related injuries. Vicki's going to be joined in her presentation by Paul Lee. Paul is a well-known and very active dementia advocate. Paul speaks for those who can't or will not, and as Paul has said in a CAMH campaign, my dementia will not hold me back. So that will be our first presentation today, and they'll be followed by Betty Daniels and Lynn Willett. Betty is the executive director of Meals on Wheels of Fredericton. She has a keen interest in applied research, having completed her master's in applied research in 2010 at the University of New Brunswick. And she also holds a Bachelor of Business Administration from the University of New Brunswick. Also, I'd like to note that Betty has served on a number of relevant committees relevant for seniors in Fredericton, including the city's Age-Friendly Committee and the MLA's Seniors Roundtable. And Betty will be joined by Lynn Willett. Lynn is currently enrolled as a PhD student in the School of Interdisciplinary Studies at UNB. She's a former inpatient physiotherapist, having worked in several provinces and on units ranging from emergency medicine, ICU, and medical and surgical units. She entered the academic sphere recently, having completed a master's in applied health services research, and she has a keen interest in advocating issues related to aging and health with a focus on policy and knowledge translation. And our third final presentation will be by Rick Barham. Rick is a PhD student at the University Laval in Quebec City and has been working as a research assistant for several years, primarily in the field of music making with older adults. He was lead facilitator and videographer for the Age Well Catalyst project entitled Making Music with the Sound Beam, which employed digital technology to bring collaborative music making to residents of a care home with physical and cognitive challenges. And since the pandemic, Rick has been investigating solutions to bring this project back into care homes during lockdown, and recently received an Age Well Graduate Student Award to help make this happen. So now that I've introduced all the important people as part of the program for today, I'll tell you just a little bit about myself. I'm a full professor in the Faculty of Health Sciences at the University of Ottawa. I've been a member of Age Well since its inception, most recently as a member of the Research Management Committee. My research has focused on methods for assessing and measuring the impact of assistive devices on a wide variety of populations who use them, and in recent years focusing on older adults who use assistive technologies. So having set the stage, let me just draw your attention to some important programming notes concerning this session, concerning the EPIC conference more generally. It may have been already mentioned, but the EPIC conference will run for 10 days from May 30th to June 10. Challenge area presentations will take place here on Crowdcast from 1 to 2:30 p.m. Eastern Time on Monday to Thursday this and next week. On Friday, June 3rd, please join us for a presentation called Making Connections, an EPIC networking event with Jennifer Polk from PhD to Life, followed by an APPTA hosted workshop. That is our major policy entity as part of Age Well, the APPTA, hosting a workshop called Bridging the Gap, Engaging in the Policy Space as a Health Researcher. Moreover, Age Well partners are hosting 4 French language sessions. This week, join the Inter-Rapar Summer School on May 31st for a session entitled Responsible Innovation and Usability of Technologies in Rehabilitation. And on June 1st, for a tour of the 3IT Lab focusing on assistive and training technologies. I encourage you to check out the Age Well EPIC Conference webpage for additional details and registration information. Now, a few housekeeping items. Today's session will be comprised of 3 oral presentations, a 5-minute Q&A session following each presenter, and an overall discussion with general Q&A that places the presentation in a larger discourse and addresses potential research impact. So as we used to say, sharpen your pencils, note some key questions that arise as you listen to each presentation, and please engage. Our presenters are very eager to hear directly from you and to be challenged if you choose to do so with your questions. All attendees are encouraged to use the Ask a Question box to ask questions, leave a comment on a question, and upvote questions that others have submitted. The session is being recorded and will be available for playback. Links to playback will be on Crowdcast and on the Epic Conference site. So unless anyone has any questions, or if any of the organizers have any further notes or announcements, then I think we can begin, I guess. Allison, is that correct? We can begin to turn things over to our first set of presenters?
Yes.
All right, so we're ready to go. And I'd like now then, it's my pleasure to turn things over to Vikki Kamisar and Paul Lee for our first presentation.
Okay, we'll just check to see this share screen thing is still going. Okay, is everyone able to see slides?
Yes.
Excellent. Okay. So yeah, hi everyone. Thank you very much, Jeff, for the introduction, and thank you, Josephine, for introducing this presentation. Paul and I are really excited to kick off this session on supportive homes and communities with some new insights on how the COVID-19 pandemic affected stairway falls in older adults and what this might mean for stair design and regulation. As Jeff mentioned, I'm Vicki, and I'm fortunate to call in from the traditional unceded territory of the Silk Okanagan Nation in British Columbia. Paul is calling in from the traditional territory of many nations that Josephine mentioned, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Wendat peoples. And both areas are now home to many diverse First Nations, Inuit, and Métis people. Okay, so first, why are we here? Well, in Canada, over 250,000 older adults are injured each year from falls. Approximately 13% of these injurious falls will take place on stairs. This makes stairs one of the most dangerous locations in our built environment for older adults. I'll now pass the floor on to Paul to talk about some of the challenges with stairs in his experience.
Okay, sorry about that.
It's okay.
Falls are complex and depend on a ton of risk factors that are linked to age. We can't stop people from getting older. However, we can control how we design staircases. So we have a responsibility to make these safe as possible. Here are some of the examples of staircases where better design would help. First, on the top left, these are stairs that are all the same color and are difficult to see and tell apart from one from the other. This can increase the risk of falling. The second, top right, is an example of staircase with non-uniform step dimensions. This is a problem because people adapt their walking to navigate staircases based on the very first steps. So challenges in the dimensions can increase the trip and overstep risk. The bottom third, bottom left, this is an extreme example of a staircase without handrails, where you hold tight to avoid falls. So a staircase without a handrail to prevent falls is a problem, especially when the staircase is steep and
did you want me to take over?
Yeah, please.
Okay, great job. Just the
Sorry.
last point we wanted to make. So these are based on conversations that Paul and I had earlier, and the last is on the bottom right. We have some outside stairs that have a 2x4 that's used as a handrail. So this is legal, but very difficult to grip. So this is the kind of thing that might work well for people with large hands, but for older adults or anyone in general with smaller hands, they would have trouble gripping this. Yeah, thanks so much, Paul. This was great. We'll just move on to the. No, it's okay. One important point is that most of our current stair design standards are based on knowledge from before the COVID-19 pandemic. So we've got this huge world around us that was developed really with a relatively healthy society compared to what we're dealing with right now. In the last 2 years, there have been nearly 4 million documented cases in Canadians, and countless more cases that were not documented. Approximately 20% of these COVID cases in adults will lead to long-term health consequences, including cognitive and physical disability. Even among those not diagnosed with COVID, there are significant and emerging health challenges that increase the risk for falls in older adults. These include the loss of physical fitness due to stay-at-home orders, as well as increased alcohol consumption that can decrease coordination. It's clear that these consequences of COVID aren't going away anytime soon. So larger picture is that we really need to plan for a less healthy society in our stairway design standards and approaches to injury prevention. So as a starting point, we thought it'd be useful to understand how the pandemic has affected the nature of injuries from falls on stairs. So in this study, we investigated the impact of the COVID-19 pandemic on the frequency and nature of injury-related hospitalizations from falls on stairs in older adults. To address this question, we analyzed the National Electronic Injury Surveillance System database and focused on falls on stairs. This is a database of fall incident reports from 96 hospitals in the United States, and it's available to the public to download. So you could actually go to the site now and get the exact same data that we used to play with for this study. We used an American database because it's public, and the outcome measures are harmonized across 96 different sites. So it's a lot more accessible and easy to work with than analogous Canadian data, in which case I would still be trying to wrangle ethics from 96 different hospitals to arrive at the exact same point. So this lets us bypass a fair bit of those hurdles to learn a little bit about how the pandemic affected falls. While we need to be mindful of differences in the health and regulatory context between countries, we can still assume that the laws of physics and injury biomechanics apply across both countries. And I think there's still a lot that we can learn from this database. So for this particular analysis, we focused on all falls by adults 65 years and above that were documented in 2019 and 2020. The database actually does have falls prior to 2019, but this was with different injury reporting standards. So it's a bit difficult to include that in our year-to-year comparisons. And we focused on April to December of both years to avoid seasonal impacts from the January to March period before COVID hit in 2020. We looked at factors like the frequency of and severity of falls, like if a person was sent home after being treated at the hospital versus kept for a long-term stay. We also looked at if alcohol was detected and the location where the fall took place. We used chi-square analysis to understand how the likelihood of alcohol use and the location of the fall differed between 2019 and 2020. So let's walk through some of the results. This graph shows the number of falls involving emergency department visits in 2019 versus 2020 from March to December of both years. So what we can see is that the absolute number of visits actually dropped in 2020 by about 17%, from around 4,900 to 4,100 in total. Most of this decrease is driven by the falls indicated in black, which represent the cases where the person went to the hospital for treatment and then was discharged right away after being seen by some professional. However, if we look at the fall shaded in pink, and these represent the cases where the person was hospitalized for at least a day, so the much more severe injuries, we can see that the number actually only decreased marginally from about 1,360 to 1,292. And then finally, deaths do not actually show up on the graph because of the scaling, but these actually increased from 6 in 2019 to 16 in 2020. So together, these results show that older adults may not have been less likely to get hurt from stairway falls during the pandemic, but they were probably less likely to access treatment unless the injury was severe enough to warrant a long-term hospitalization. This shows that declines in reported injuries with the COVID-19 pandemic need to be interpreted with some caution, and are more likely to reflect treatment access issues rather than safer stair behavior and outcomes. Okay, let's look now at alcohol outcomes. So this graph again indicates the number of falls in 2019 and 2020. So black indicates no alcohol, while gray indicates alcohol use. And first we can see that in both years, alcohol was not implicated in the vast majority of falls, which actually surprised me to some extent. I thought that our society was more heavy to drinking in this, but I guess we stay away from falling on stairs. In 2020, however, even though the number of emergency departments visits decreased, the number of falls with alcohol increased by about 12%, and the likelihood that alcohol would be linked to a fall involving an emergency department visit increased by 1.3-fold. These differences are notable when we break things down by gender. So most of the falls involving alcohol use were in males in both years. So this would be about 3/4 of the cases. But the number and proportion of falls with alcohol increased by 50% in females in 2020, from 49 in 2019 to 73 in 2020. And this is consistent with population data that show more widespread alcohol use in Canada and the US, especially in females. Lastly, we looked at the location of the fall. So this graph shows the falls where the location was known, which we split into the person's home in black versus elsewhere in gray. This representation is a bit different from the ones that I just showed you, where I'm showing the percentage, or the fraction of the falls rather, that were at home versus elsewhere. So what's most important to learn from this is that in both years, most falls that involved an emergency department visit took place at home. And in 2020, the percentage of falls at home increased by, or the likelihood of falls that a fall would be at home increased by 1.8-fold to over 90% of cases. This is consistent with stay-at-home orders and social distancing and stay-at-home encouragement, and generally people being less likely to go out in 2020. While we don't have analogous information available to my knowledge in Canada, this is especially relevant because the building code requirements for home staircases are much less strict, especially when it comes to the steepness of staircases and for the presence and geometry of handrails. So things like the 2x4 are legal in private homes, but not so much in public dwellings. The justification for the laxer home stairway safety standards becomes a bit more tenuous when we see that the likelihood, or that over 90% of falls with emergency department visits took place at home for older adults during the pandemic. So while people are going out a bit more, the most recent data that I'm aware of suggests that people are still spending more time at home. And given the function of staircases is the same at home and in public buildings, our findings provide further support to harmonize the codes that govern the design of public and private stairs. Okay, I will now pass this back to Paul to discuss the takeaway messages that we hope you learned from this presentation. So Paul, back to you.
Okay, thanks, Vicki. Serious injuries from stairway falls still common in 2020. However, access to treatment may be limited for less severe injuries. While alcohol was not a common stairway fall injuries, it was more frequent in 2020, especially in females. In injurious falls on stairways are more likely to occur at home. This supports the potential benefit of harmonizing building standards between homes and public spaces.
Okay, thank you all so much. We will be very happy to take any questions.
Vicki and Paul, that was very, very interesting. And we do have several questions here. The first one is a request that you provide the link to the site that you referenced. Is that doable, or can that be put in the chat box perhaps?
Yeah, I just need to pull it up. Yeah, it's a really super useful website. They publish the results from any of injuries from any consumer product. I guess people like to sue the pants off each other in the US, so that's where this all comes from. I'll dig up the link and put in the chat in a few minutes once I find it again.
That would be great. All right, are you ready for another question?
Go for it.
Next question. Did you consider the age distribution in this data set of older adults?
That is an excellent question. So what I think, just to clarify, what you're getting at is whether we consider people who are, say, like 65 to like 70 versus people in their late 90s. So that's kind of next on the docket. I did some very quick analysis there, and I'll be honest, the results were a bit difficult to interpret at this point. It's certainly an important consideration because we know that injury patterns differ as people get much, much older compared to the 65 to 75 crowd.
Right. Yeah, I imagine
so
that's
next year.
Yeah, I imagine that's what we're looking for here. Is as you segment that population, is it the older, perhaps more frail, that are accounting for some of the changes? Okay, thank you. The next question, it says, Dr. Komisar, could you speculate on the impact of the pandemic and social isolation on increasing alcohol use and falls?
Oh man, I'm seeing a number of the qualitative experts in the crowd here, so I kind of encourage you all to weigh in on this. So based on what we saw in the literature, we did see a number of reasons. First of all, the alcohol use increased, and what really surprised me was that the increase was driven in part by women, partly because females seem to, sorry, these are sex differences here, not gender, so I'll stay in that area. Alcohol use seems to be less in females to begin with, so a small change will be more noticeable in the pandemic. What we do know also is that people did go out much less. If we think of, say, older adults, the activities that a lot of people previously did, like, say, group exercise class, were canceled when the pandemic hit, and we didn't really see people flocking back to return to those as soon as things opened up again. So as alternatives to passing the time, people stayed at home. I know Paul and I do a regular Zoom call like every few weeks where, yeah, we'll probably do a drink or two, and that's a way of like stopping isolation. But a lot of we'll call the physical activities have been replaced by sitting at home and drinking, maybe watching TV or a movie. So I don't want to talk too much more about this, and I encourage others who kind of know the qualitative sphere a bit better to maybe weigh in on this. But it certainly seems to be an artifact of the social isolation. I wonder if this is something actually that Paul wants to add to.
At this time, no. Sorry.
Okay.
Okay. Next question is someone is asking, they may have missed it, but what is the percentage of stair falls in all at-home falls?
In all at-home falls, oh my goodness. I would need to look this up. We know that stairs are 13% in total. What I can do is I can dig this number up and put it in the chat box in a few minutes. So okay. We know that the homes are by far the most common location of falls. I just don't remember the number off the top of my head, but I can get that in a few minutes.
Okay, now we have I think it's a comment here by Farnaz, and I'm not sure, is Farnaz part of your team, your research team? Anyway, there's a comment by Farnaz that says, we are not sure if the elderly were alone while falling or their caregiver or families were there. So can we conclude that the falling at home is just due to the designs of the stairs?
That's an excellent question.
Let me just finish the thought there. So that's the question. And then the following thought is, maybe when the elderly are out, they have received better care from their families, or they have used any kind of assistive devices like walkers from their families.
Okay, that's an excellent set of questions. So I put the link in for the download site into the chat box, so you can get a sense of what we're working with here. We generally don't have the level of contextual information to know if caregivers were present. We do have very concrete epidemiological evidence from the United Kingdom to show that stairway step dimensions affect fall risk. So your risk of falling increases as the staircase steepness increases. So independent of caregiver presence, there's certainly parts of it that I think we can attribute to design. You know, and it doesn't tell the whole story, but it's one factor that, again, I can't control if a caregiver is present. But as an engineer, I can do something to push forward regulation to control the design of staircases in homes. With respect to the comment on assistive devices, this is a very challenging one because things like walkers, people tend not to really use on stairs, right? So I think that's a bit of a difficult area to maybe consider. What we do know is that if people are looking to make some kind of modification, that might be a bit easier to do in a home staircase compared to a public one where they're really more subject to what's available to them.
Okay, and Paul and Vicki, maybe we can squeeze in one more question and then we'll need to move on. Can you speak to any examples of policies where the home versus public building standard is harmonized? Would this result in added cost to older adults to upgrade their dwellings?
Okay, that's an excellent question there. So I'll first start with the harmonization. So things so this is tricky across jurisdictions. In the Canadian model standards, so the way it works in Canada is that we've got the federal body that sets the model codes, and then the provinces will decide whether or not to adopt the model standards. So we might see harmonization in some areas, but that not get adopted in 100% by the provinces. Handrail height is one example where we do see harmonization across public and private stairs. The code is not applied retroactively, so a change to a code is not going to result in having people rip out their staircases and install new ones. But it does provide extra impetus for an upgrade because there is a standard right there that says, hey, you know, just there's been a policy change to reflect better knowledge in design and fall prevention. We might see a greater initial cost on the stairway step dimension side for initial builds in homes because stairs that are less steep will occupy a larger footprint. The cost that I'm not sure that it outweighs the benefit of potentially avoiding injurious falls in staircases, given the established relationship between staircase steepness and fall risk, and especially in older adults. So yeah, the cost question is dicey in part because you're trading off a renovation versus the need to provide care for someone after they sustain a serious injury should they fall.
Okay, thank you very much. Vicki and Paul, excellent presentation. Those of you out in the audience, if you have an applause button, I suggest now's a good time to do that, register your approval, or if you want to add any other questions or comments, please use the chat room for that. And at this time, then, I'd like to, my pleasure, to turn things over to Lynn and Betty for their presentation.
Thank you very much. I appreciate this. Allison, I think you may have our slides because I think our share screen wasn't working.
Okay.
I can try it again though, but.
Yeah, maybe give it a try. I will also, mine's open but not showing up, so I'm going to close it and open it again. The joys of technology brings us together, but yeah, let's see if that works. Okay, so I can see mine. Does that look okay?
Great, thank you.
There we go. You got it.
So we'll just kind of let you know when to move forward. So thank you, everybody, for your time and really appreciate this opportunity to be able to present. My name is Lynn. I'm a research coordinator and PhD student in Fredericton, New Brunswick. I'm really excited to be here with Betty Daniels, the executive director of Meals on Wheels in Fredericton. They're an organization who are already doing a lot of really great work. So I'm glad that they get to showcase that for you all today. So to give you a little context, you'll see in the next slide that there's a little bit of story as to how we got here today. Our community has some great energy behind it. And this really actually started in the fall of 2019, back when people could actually meet in person. About 50 organizations, of which Betty was a part of it, met to discuss issues in the community, mostly related to older adults. And they felt that they were kind of seeing the same people over and over again. They recognize there's a lot of great resources in the community, but they weren't reaching everybody that certainly could benefit from them. So they wanted to know, how can they support their community and ensure that everyone has access to all available resources? So they contacted my supervisor, Dr. Banerjee, and he devised the first study, and that's when I came on board. We started from the viewpoint of social isolation and loneliness. We looked at the literature, and that was our first opportunity to collaborate with Betty. They identified older adults here in the community who are isolated and lonely. So we were able to interview them and really understand the issue from their perspective in this community. What we found in the literature is social isolation and loneliness has a huge impact on the individual and on society system at large. So if you are isolated or lonely, you are at increased risk of dementia, of cardiovascular disease, all sorts of things, including you're at increased risk of mortality. And kind of an often quoted paper published in 2010 showed that those risks are equivalent to smoking, to alcohol use, and they're even higher to the risks of being obese. Now, what's interesting about that article was in 2010, and I think we're all, kind of aware of the negative effects of smoking, alcohol use, et cetera. But really, until the pandemic, the issue of social isolation and loneliness and its impact really didn't get a lot of attention. But a place that it did get a lot of attention was the UK. So in that first study, I also did an environmental scan looking at all sorts of practices around the world. And indeed, some of our community has developed their own projects from some of those things that were identified. But we identified a project in the UK that we will be using. So the UK already has a Minister of Loneliness, and they have since 2018 that sits in Parliament and has all things related to loneliness in their portfolio. They have national strategies and have for decades to bring awareness to the issue, all sorts of things. And they have the program that we're going to be developing. So on the next slide, you'll see who is a community connector. So you may have heard this word. I know even here in New Brunswick, we have a couple of community connector programs happening, and everybody's is a little different. In our community connector program, anyone who comes in contact with others can be a community connector. So the program that we actually have been speaking with in the UK, and they're helping us out, they have trained taxi drivers and grocery store clerks, coffee baristas, all sorts of people, even have trained people who experience homelessness to become community connectors as well. And the program is really about providing opportunity in random encounters. And a great way to understand that is you could be sitting at a bus stop and you yourself are a community connector. And perhaps there's an older adult sitting there and you strike up a random conversation, probably starting with, how's the weather? You continue on and the older adult happens to say, oh, I'm on my way to see my husband. He's just had a stroke. You as a community connector have been educated to understand that this is a pivotal moment in this person's life, that issues could come up. And you have been provided with a resource to make a recommendation in that conversation. So you could say something to the effect of, I'm sorry to hear your husband has had a stroke. I don't know of any specific resources available to help you with that, but here's a central hub that you could contact and they may be able to direct you. Now, what that's done is it's created that connection, that human connection with two people, but it's also let that older adult know there's a community out there supporting them. There's resources there that maybe they weren't even thinking, oh, I could contact somebody and help me out in this situation. So as you'll see from the next slide, we're very early stages. I'm in the process of doing case studies. So I have spoken to kind of our primary people in the UK, as well as some people here in Canada developing community connector programs. We're really fortunate. The people that we're kind of basing this off of is going to train us to train our connectors. So I think that'll give us a really solid foundation. I continue to have great communication and input from Betty and Meals on Wheels. They will be our first community connectors. So they keep me on track. I let them know what I'm doing and they let me know if it sounds reasonable or not. And so in the fall, we'll be creating and kind of doing the pilot. Absolutely imperative that we develop a website to house all materials related to this. Everybody I'm speaking with talks about how you need a central hub, a localized area for all issues related to this project. So I'll be doing that, creating our training sessions, and then obviously feedback from both the older adults and the community connectors to see how our pilot went. And so to let you know how these community connectors are doing such great work already, I'll pass it on to Betty.
So if we can move to the next slide. Thank you. And I echo Lynn's comments. It's an honor to be here. We're delighted to be sharing our project with all of you. And our information tells us that Meals on Wheels dates back to wartime Britain during the Blitz of London in the Second World War. And Meals on Wheels was founded on the concept of neighbors helping neighbors. People saw a huge need when citizens, particularly older adults, lost their homes, they were unable to get food, they were suffering from a variety of disabilities. And the story goes that community volunteers prepared nutritious meals. They put them in wheelbarrows and old prams, and they covered them with straw to keep the food warm, and they delivered them. We have photos of these early Meals on Wheels, and it is amazing. I love looking at those pictures and the stories. Fast forward 80 some years, and this concept continues, and it has evolved. Meals on Wheels programs exist in many countries throughout the world. They exist, I believe, in almost all of the provinces in our country. And in our city of Fredericton, New Brunswick, a group of women in a local church became neighbors, again, particularly older adults, not eating properly for a variety of reasons, and they decided to bring a Meals on Wheels program to our city. This was 1967, and 55 years later, we have gone from those early beginnings of preparing maybe a couple of dozen meals in the basement of a beautiful church downtown to where we're serving over 300 meals a day, 7 days a week, 365 days of the year from our own kitchen. And so if we can maybe go forward to the next slide. Research completed by the AARP has provided evidence that we were already very aware of. And that is that Meals on Wheels is so much more than a meal. Maybe we can go to the next slide. It is, if we could just move forward one more, it is, it's so much more than a meal. It is the visit from a community volunteer that can make such a big difference. We've known this from surveys. We've known it from regular phone calls with our clients. We hear it all the time, what a huge factor this is. We've been told that it is the reason that some of our clients get dressed in the morning, how important it is for that trusted member of our community to come to their door and bring them that meal. We took our program one step further in the year 2000, and we began what we call a Wheels to Meals program. And that is a weekly luncheon with local entertainment in a local church again. And what was unique about our program is that volunteers would go and pick up individuals, older adults, and they would take them to the church for the luncheon, and then they would go and bring them back home again. And some of the conversations that happened in those drives to and from those luncheons are amazing. And they speak so loudly to how important this is. The pandemic, sadly, has played havoc with our program, but we do look forward to having it again in the fall. And that brings me to why Meals on Wheels in Fredericton is involved in this research project. It is because we believe in it wholeheartedly, and we speak from experience. We believe that the concept of neighbors helping neighbors is a concept that is needed now more than ever before, partly because of information and research that we know about the impact of social isolation on older adults, and also because of an unprecedented health crisis that we have all just endured and continue to. We believe that what Lynn has spoken about, what this project is a beginning. It is a place that we can begin. We can find out whether or not this concept of community connectors has legs, I guess, if you will. We can find out if our contribution can bring greater awareness and a greater understanding of isolation and loneliness, and what may be necessary for us to address this ever prevalent issue in all of our communities. So on behalf of Lynn and I, thank you for listening to our, I guess, enthusiasm and excitement of this project.
So let me pose some of the questions that have come up to you. First one is, the community connector idea is neat. How are community connectors vetted or trained? Is it purely volunteer based?
So this is a question I actually spoke with our UK partners a few weeks ago, and the message that is being given is simply, here's a resource. So you don't need to vet anybody. It really is just trying to create an information network, and there is nothing more to it in a way than that. It's interesting in its simplicity and yet its effectiveness. So no one needs to be vetted.
Okay, thank you. Next question. Can you speak to the regional differences between potential uptake of the community connector idea? I think of downtown Toronto versus a smaller or rural town.
So that's a great question. And obviously, this particular community that we're basing this off of was, what you would perhaps call rural in itself, but still in the UK, so still quite connected. And what they found, they were getting a lot of out migration, a lot of people leaving, and this actually created a sense of community. They have since now partnered with communities all around the world to create this program. They were featured in the New York Times in January. They have partnered with larger urban centers and have found it to be effective as well. The initial program, just to say too, they showed how it decreased hospital admissions, decreased healthcare costs. And so it can be carried out, again, in its simplicity, can be carried out really anywhere.
Okay, that's great. Next question. Can you elaborate a little bit on the notion of a central hub, in-person versus virtual, for example, staffing, tools, etc., and how it's funded?
So that's exactly where, and Betty can attest, we have great community representation that we still speak with. And this central hub is something we continue to discuss, create, try and understand. So obviously we're talking about creating social networks and connections and getting that networking out, but that information still needs to be housed centrally somewhere. That thing where you're saying, hey, this is where you can go to, is a challenge. And that's what we're in the middle of. And that's so we think right now our biggest resource would be 211, for which we've here in New Brunswick just kind of had the opportunity to have 211 in the province. But they are still limited in what can be inputted into their website, which is why our website as well, we're still wondering what we're going to house on it, what we can keep up to date. I'd love to have things. We heard from a lot of older adults, something as simple as someone shoveling or mowing their lawn, or even just small house chores would keep them in their home. And those resources are hard to identify and then house somewhere. So for sure, that central hub is probably the biggest challenge of our project, but we're working on it.
Oh, that's great, Lynn. Lynn, there's one more question that I want to leave with you, and then we're going to come back maybe when we have the open session, the panel discussion. It's an important and timely question, and I think it deserves an answer, but we need to move to the next presentation first. But the question is, it sounds like the community connector connections would be random and occur in the community. And if yes, how will you measure impact? So the question will be, when we come back to you guys, can you tell us how you propose to measure impact? So Lynn and Betty, thank you so much. Very stimulating presentation. And again, those of you out there in audience land, please use your applause meters appropriately here and register your approval. That would be great. And our next presentation, I'm happy to turn things over, our final presentation of the day, Richard Barham. So take it away, Richard.
Oh, okay. The screen kind of flipped around. I didn't hear what you said previously, but hello, and thanks everyone for being here and inviting me. Basically, I'll just go straight to sharing my screen. Hold on a minute. Okay, hide that, and oh, I hear a dog. Okay, can you see the first slide there?
Yes.
Okay, great. Okay, so if I put it in full screen, are we now in full screen?
Yes, we
Jeff?
are. Yes, we are.
Excellent. Thanks. And when I show the video, let me know if the sound doesn't work, okay?
Okay.
Okay, so back in 2019, I was the lead facilitator of this research project put together by Professors Andrea Creech and Aaron Liu Rosenbaum, which involved bringing music making into a care home with the help of digital technology, most notably the Soundbeam system, which involves motion sensors and touch-sensitive switches to create almost any sound one wishes, from sound effects to musical instruments. And as you will soon see in a short video, the system was augmented with iPads running music-making applications. And I should probably note that only one person in the group had previous musical experience and that all participants have significant cognitive and physical challenges.
This one. Yeah, this one is on. Yeah, this one is on. That's on.
Inspector Clouseau. By looking for clues. There you go. One more time. That's great.
Wait, let's go ahead.
Oh, I see.
Comme l'on sent, c'est les émotions.
And everybody out. Yes. Well, we had just enough time to award everyone a diploma for their first round of sessions before lockdown was declared and the project was effectively shut down. No sooner did that happen, I began investigating a way to get this project back into the care home through the aid of virtual connectivity. In other words, a fully portable, plug-and-play, pandemic-proof system that allows a single caregiver or a volunteer to continue creative activities during a lockdown, while researchers and facilitators, and even family and friends, participate from afar. And everything would fit onto this. Hence, TRIL, or Continuing Creative Connectivity in Care Homes. And last fall, AgeWell provided funding to go forward with this project. I don't mind saying I was rather chuffed with myself. And then academic reality kicked in. The first challenge was, and continues to be, ethics approval. Until this has been cleared, the AgeWell Award I received is held by the university, and no further research is to be carried out with the residents of the care home, including the participants I worked with during the original sessions. However, I had already applied to become a volunteer at the care home, which put me together with other volunteers and caregivers, and in contact with various administrators, which soon led to a proposal for the care home itself to finance the hardware for the TRIL project. In other words, the project equipment would no longer be on loan from the university, it would actually belong to the care home. A cost breakdown was submitted to the appropriate committee, and after a few delays due to the pandemic, the committee met in February of this year and turned down the proposal. This, of course, points directly to an important part of any innovation process: failure. What went wrong? Where was the fault point? It's right here, of all places. The very aspect of the project that was so important, virtual communication. Just below the red circle, you will notice the category Service and Warranties, which includes service and support for a laptop, iPads, and the Soundbeam system. But nothing about the virtual connectivity system, which I would be putting together myself. The committee quite rightly asked, who is going to maintain and support this? Not just now, but in the future. And that question leads us to another important aspect of research and design: ethics. Who exactly am I designing this for? Have I truly taken their needs and concerns into account? Can I put myself in their shoes? Well, lockdown was finally easing, and I was now working as a volunteer, right alongside the caregivers and other volunteers, floor to floor, room to room. I was now experiencing the care home from an entirely different perspective. And the same committee who turned down the proposal, by the way, didn't discount the project outright. They knew and appreciated the TRIL concept, and they indicated that parts of what I had already proposed might be paid for through various expense budgets. In other words, through trial and error, bit by bit, step by step, the system could be financed and built. Or, as explained in the AgeWell courses, the iterative, and one might even say inclusive, nature of innovation. And here's the latest cost breakdown, this time divided into phases according to immediate necessity. And right at the top is an important item that I had not foreseen, but certainly should have: a portable power pack. I had originally proposed this system as plug and play, but it actually needs to be play. In other words, plugging in power cables that snake across the floor of a busy care home with walkers and wheelchairs is not a practical solution. So, a portable power system is needed that can deliver not only a fair amount of power, but a pure sine wave to protect sensitive electronic equipment. And it's already paid for. The largest contribution coming from the Catholic Women's League of the tiny municipality of Shannon, Quebec. In other words, welcome to the iterative nature of funding. So what's the takeaway from all this? Well, the minute you have an idea in your head, think ethics. Take the Age Well courses. They're free, they're highly informative, and they're very well put together. Think iterative innovation and even funding. There are all sorts of individuals and groups out there who would like to lend a helping hand. As for ethics, think about your stakeholders and iteratively go through every step and aspect of your research and documentation. Let your ideas and procedures percolate before submitting anything for ethics approval, because once approved, it's pretty well baked in and can't be modified. And lastly, volunteer. Get in on the ground floor and get to know your stakeholders. Personally, I think I'm having a lot more fun as a volunteer than as a researcher. As for my project, I'll be tinkering away through the summer, fall, and winter while testing and troubleshooting on site. And I feel quite confident that around this time next year, I'll be able to show you the complete system, battle tested and fully implemented in the care home. Thank you.
Thank you, Richard, for that most refreshing and insightful presentation. I really enjoyed that, and I'm sure our audience did as well. Your first question, Rick, are the sounds preloaded and respond to movement, or are the users choosing notes via their movement?
Well, actually both. First off, there are pre-recorded sounds already included with the sound beam. However, you can put any sound in there you like. It's also a sampler. So you can, for instance, we actually, for those tracks that you saw with B.B. King and Miles Davis, we actually pulled official backing tracks off of the internet and then completely simplified them on the beat and all that. And then we ported them into the sound beam system. But you can make pretty well any sound you like. And the motion is essentially normally, say if you take your hand up on a sound beam, the notes go higher. You take it down, they go lower. So what's being created is and you can set the keys, that's the thing. So you can set the keys of the sound beams and the iPads. So they're all completely on the same level, as well as the backing track. So all someone needs to do is move their hand up and down, and they can make a lovely melody that matches the rest of the music. Okay. But you don't need to just use a hand. You can use your whole body, and we have people using wheelchairs as well to actually activate the sound beam.
Excellent. Okay, next question, Rick. In terms of ethics, how would you have approached things? How would you have approached things differently?
Oh, well, that's a good question. Well, basically, simply knowing a bit better or a bit more about the stakeholders. You see, I had only experienced the care home from those sessions that you saw before the pandemic. So I'd only seen the care home downstairs in that gathering room. I had never seen the real workings of a care home on the floors, right? And that really is a different perspective. And of course, the perfect example was the business with the power pack. I should have seen that coming, right? So yeah, and there are different things. I should probably say too that, in all fairness, when it comes to ethics approval, I'm actually waiting on that because I'm really letting things percolate. And then when I know exactly what's needed, that's when I'll submit everything.
Okay, next question. Could you speak to the university research-led research versus doing this sort of thing as a startup? Do you know that?
That's also a good question. Yeah. Well, I would say if you do it as a startup, you're not as constricted. Ethics approval right there is one thing, right? I mean, basically, which is understandable because once you are a researcher and you represent the university's reputation is at stake. But when you simply go in as a volunteer, for instance, a colleague of ours did some fantastic sound beam sessions just recently in British Columbia in Nanaimo. And, approval and that kind of thing was very, very easy compared to, say, officially doing it through a university.
Okay, then one last quick question. Did you then need to purchase copyright for the music?
Well, we didn't, let's put it that way, but this is not being used in a commercial sense. This is all, there's, as far as it goes for the actual sound beam system itself, if that were to be used for commercial purposes, in other words, to make money, then probably be a much different aspect. But I will confess, I haven't really looked into that.
Okay, well, thank you, Richard, again. Excellent presentation. And those of you in the audience, if you haven't already, Please register your approval with virtual applause or comments as you see fit. And at this time, then, where I think we're ready, unless Allison or Sam, if you have any other programming notes, I think we're ready for our ask a question session portion of the presentations today. And so I guess we're open. Anybody who has any questions, but maybe we could lead off going back to Lynn and Betty on the issue of the very important issues, an exciting project like this, community engagement, all kinds of variables. How do you do it? How do you measure the impact of something like this?
So this is something that I'm excited about because I think this will be the first time in this sort of project that we know of that this part will be examined. The original study and others who have kind of had this type of program have kind of noted that it is a bit of like a message in a bottle. You throw out this message and you don't know if it will be acted upon. And so perhaps being a bit of a sucker for punishment, I'm actually going to be doing a systematic review on, first of all, just how do older adults become aware of community resources, period. But awareness is different than accessing and using. And so we are the awareness part, our program. And certainly you can't access a service if you don't know about it. But that part of then what gets somebody to go out and actually make use of that resource is the next part. And again, thanks to Betty and Meals on Wheels, we will be giving our community connectors logbooks. They'll be, getting different pieces of information, but we're also going to be then asking the older adults, what was that like? Did you connect with family members? Did you access the resource that they mentioned? Did you increase your activities? So we're going to be getting a little bit of an insight as to what that is. And how many conversations did it take? Did it take one and you went out? Did it take 10? So we'll start to put those pieces together.
Okay, thank you. And maybe just while we're waiting for some more questions to come in, I wanted to go back to Vicki and Paul for a moment. Vicki, I think at one point you said something about in contrasting the 2 years, 2 time points in the study, about there being more limited access to treatment. I assume treatment for falls or something. Well, why do you think that is? Is that because, are you thinking of because of COVID cases preoccupying, emergency units or something? Is that the?
Yeah, so I think that's one possibility, and especially in it's hard when you're dealing with a large geographical area and the right. I guess pockets of outbreaks are different. But yeah, emergency rooms filling out is one. The other is people simply being afraid of going to the hospital. So I think of my grandparents, for example, and their threshold for getting treatment for anything shot up with the pandemic because they didn't want to set foot in a hospital and risk getting COVID from other patients. So I think both of those factors are at play there.
Okay, thank you. We have another question here for Rick. Rick, has there been any interest in merging dance and music in your project?
Oh, most certainly, yes. The thing is, though, it really depends on whether or not someone is physically capable of dance. But no, we do encourage that. Yeah, in fact, some of you probably saw in the pilot session, right? We actually simply had people twirling through the beams. No, dance is definitely encouraged, and I think it'd be quite therapeutic. And one thing we've also noticed too is we try to encourage people. We sometimes will you can set the range of the beams. They can be very close for people who have limited movement, or you can actually make them like 5 meters long if you like. But for people who, don't get a lot of movement, but maybe in a wheelchair, what we like to do is try to set the beams higher and higher to give them some movement. And this does produce an improvement in gross and fine motor skills.
And maybe again, I'll while we're waiting for some more questions to come in, I'll use my prerogative as chair to ask something. If we can go back to Vicki and Paul, and back to Richard and Lynn and Betty. In each case, if you give some thought to the following question: what might be the benefits of extending this kind of research project nationally, having at least a few sites, two or more, in various parts of the country. Can you comment on the pros and cons of doing that in terms of advancing your fundamental objectives? So maybe, Lynn, do you want to lead off on that one?
Sure. And maybe even Betty can chime in, because I know with Meals on Wheels, and you can speak to it better than I, it is very regional, is it not? It's not, there's no kind of national.
In Canada,
And so
Canada there is not.
So we're kind of, again, this collaboration we're very excited about, because maybe there's that opportunity as well to bring that along. I don't know if you want to expand, Betty, on that, or
I think, when that question was asked, I thought, what a great question, because I don't think it is all, that it is specific to where we are. And I would love to know how, maybe work with Meals on Wheels in other provinces in Canada and try and approach it from a more broader sense. I think it's a wonderful idea to do that. And I think the whole issue of social isolation and loneliness is universal now, and has been, and that we could learn a great deal from that type of collaboration.
And as a national network, each will may be in a position, depending on the way it's you present that kind of opportunity. Richard, do you want to comment?
Sure. Well, first off, one thing that occurred to me, I love, first off, the moniker Community Connectors, and it immediately made me wonder if I could come up with something like Creative Connectors, right? In other words, connecting people creatively. And of course, this whole thing is about social isolation. And when it comes to having it on a national level, like in other words, having doing something about it on a national level, I think that's imperative. Essentially, we need funding on a federal level that simply says right across the board, what happened during the pandemic, especially to senior citizens, will not happen again. And I don't know, when it's appropriate, I could probably give you a short quote from, I don't know if you're aware of a recent report by the BC Seniors Advocate. It's very sobering, very interesting, and quite eye-opening. But it deals with the whole business of the pandemic and families trying to see their loved ones and that sort of thing. But there's a quote in there that would be highly appropriate to essentially what we're discussing and thinking about.
Maybe, Richard, as well, if there's a link, you might want to post that in the chat, if there is actually.
Well, I'll post a link
via
to the actual seniors report, because I'd qualify that as a must read. Yeah. But on this,
excellent. Next question. Oh, sorry. Did you?
No, go ahead. Go ahead.
Yeah. Okay. Next question is for Betty. Betty, can you speak to how your organization works closely with researchers to do these sorts of projects? Are there any other examples?
I think that it's a great question, and for us, it's somewhat of a new direction. We have always believed in the importance of community and of being part of a community, and then being part of our university community and taking it just that step further. But one thing that helped to make this a reality was Lynn's tremendous interest in this area, mine as well. We share a program that we were both involved in our master's degrees from University of New Brunswick. And then Lynn became a volunteer for Meals on Wheels last summer and volunteered herself and then with her children. And so I think when you start to bring those connections together, the sky's the limit, and we don't plan on letting it go at that. Like, I just think it's just a wonderful way to bring those two worlds together. And we were just fortunate that we had this connection in a kind of unique and interesting way. And the fact that she reached out and volunteered for us.
And it goes to your point, Rick, about volunteering. There's nothing like it. And I wasn't doing it at the time. We didn't have this project necessarily but and yet doing it allowed me to see what those interactions are like. And now that experience is invaluable in moving forward in this. So I echo what you were saying. Yeah. Volunteer, everybody.
Oh,
Anywhere.
absolutely. I'm loving it. I mean, you
Mm.
know, and I volunteered here and there throughout the past, but nothing big or anything like that. But I don't know. It's so much fun working with these seniors on a more personal basis too, because they
Yeah.
tell you all their stories while you're wheeling them into the place you're going to do the music with them and stuff. And you know, we've become totally known throughout the care home. All the caregivers know us, you know, and all the volunteers and administrators, because instead of just doing an occasional event in a room, at least twice a week, we're literally jumping floors right up and down. And you know, as I said to, you know, my colleagues, I almost feel like a hot dog vendor on the streets of New York or something. I was just wheeling this thing back and forth and making music with people. And it's,
Excellent. That's great. Okay, next question here is for Paul. Paul, can you speak to the value to you of working with researchers on projects like this?
Well, first of all, I have vision issues because of the stroke that I had. I have depth perceptions, and I had complained for a long time about in public places the last step. It's all the same color, and I have a tendency to go over it, and I have stumbled on many occasions. Even though I have a death grip on the handrail, I still have stumbled. What this project does, it opens up like a Pandora's box to all the problems in home. Like the handyman putting a carpet or a runner on stairs to try and stop someone from sliding or anything like that, but they don't sometimes use the proper materials, and those carpets can go loose and the person can fall. There's that sort of thing. And Vicki and I talked about many things, and it's frustrating what goes on, what's allowed, and especially like the handrails. There was one picture where there was a steep set of stairs, and that scared the hell out of me. I would never want to do that. Even escalators. I grip the handrail because I'm afraid of falling. So what Vicki's research is, it's opening doors, opening ideas, getting people to talk about it.
Excellent, thank you. And I think this next question, I believe this goes back to Lynn and Betty. Comment and the question: social isolation and loneliness is not only an older person issue. Younger adults have similar concerns, so there should be a more of an intergenerational approach to this, and make a direct hit on contacting high schools and colleges to make community connector projects more robust. How about that?
I love that.
Absolutely.
Yeah, I love that idea.
Yeah. And, you know, it's funny. Obviously, I've been so focused on issues related to older adults, but I have been reading more. And the numbers, to be quite honest, with the younger generation, is that their numbers of isolation are higher. And what's interesting, so the UK identified a minister of loneliness and implemented that in 2018 because of issues related to older adults. Japan in February of 2021 is the second country now to have a minister of loneliness. And their reason was because of younger people experiencing isolation and loneliness. So absolutely. I think we also, I mean, this comes to the conversation. I think we all know, you know, we kind of treat issues sometimes of, you know, a certain age because, oh, that's a moment in time. But life is a continuum. And certainly something that perhaps is happening at an older age is because of something that happened at a younger age. So I absolutely think I agree. It's all related and important. Yeah,
I agree wholeheartedly. Yeah, and it's a discussion that we have we have what we call age-friendly organization in Fredericton, and that discussion comes up often. The need for age is not only older adults.
Mm-hmm.
Yeah.
Very good. Thanks again to the questioner for that. Yeah,
Could I
Richard, did you
possibly
want to
just
comment?
add to that quickly? Because that
Yep.
goes back to a discussion we had for a little while ago now, an HWell webinar. But basically, there's the concept, because we're talking about younger people and older people, and I'm a big fan of the idea of putting the very young together with the very old, because we all know from experience, right, that especially when we're teenagers, for some odd reason, we can understand our grandparents perfectly and they seem to understand us perfectly, but we just don't get along with our parents, right? And that is a perfect opportunity, right, to put young and old together and, creatively and whatever.
Excellent. In fact, our next question then, Richard, goes back to you.
Mhm.
Are the results of the project, can the results of the project, can they be the basis of developing an assessment method for detecting early stage of dementia?
Yes, I saw that in the comments. Yeah, that's an excellent question. Well, I can't answer whether or not I haven't tried it. I mean, it's certainly, most certainly think it could be because using the sound beam, there are aspects of it that are similar, right, to various tests when it comes to dementia and that sort of thing. But I can say one thing when it comes to cognitive decline or improvement. And what we've noticed repeatedly, and I mean repeatedly, right, is how music seems to be able to access areas of the mind that other forms of communication no longer can. It's really quite stunning sometimes. I've seen people, you can't speak with them because they can't speak and you're not sure that they even understand you at all, right? It's kind of a blank and you're there, geez, how do I approach this and all this? And then next thing you know, they take to the sound beam and they're just right in it. And there's this communication and they even collaborate with others. It's quite astonishing.
Okay. And I wonder, too, if I can sneak in a question of my own, going back to Vicki and Paul on the issue of stairs, staircases, and falls. Overwhelmingly in this arena, we tend to view stairs and staircases as a danger zone, and the whole thing is about trying to make improvements that will prevent people from falling. But as I understand this, and maybe you know more about this, Vicki, there's some research that really promotes the benefits for older people of continuing to use staircases, if at all possible, for purposes of mobility and actually the integration of cognition and motion and motor, that it's very beneficial physiologically and perhaps psychologically as well. For them to continue to do that. Yeah, we don't typically hear too much about the health promotion aspects of stair negotiation, stair climbing, and descending with older adults. Did you want to comment at all on that?
Yeah, sure. I can, I'll maybe draw on this. I don't know the epidemiology of that super well, but I can speak to some stakeholder experience. Some of the network may be familiar with, my great grandmother used to live in a Manhattan walk-up. So we're talking 6th floor in a building with no elevators. And she actually lived until the age of 90. She would walk up and down those stairs every single day to get her fresh groceries and to meet up with her friends to play mahjong. And actually what ended up, kind of what didn't work for her was when she bent down one day to fix her sock and fell over and fractured her hip, then went to the hospital and didn't return. So, in that case, it absolutely wasn't the stairs. And for her, they were really instrumental to being able to socialize with others and, get the food that she loved eating and the games she loved playing. So I can see, I know certainly when we look in care settings, things like sit to stand can be encouraged because they increase strength. You could probably make a similar argument for stairs. I'm not a clinician, so I'm not going to, comment too hard either way. But what I will say is that if people are going ahead with this, as a means of really important access and getting around, this is where it becomes so important to have things like good handrails in place. And ensure that these are maybe held on the way down, because when people fall while holding the rail, they're a lot less likely to get hurt, as well as ensuring that, maybe the stair climbing isn't done on the steepest staircase in the home, but something that's a bit more manageable and lower risk. So, is Jeff frozen?
He does look, yeah.
He's very interested.
He's contemplating.
We lost it. Oh dear.
You look softly frozen to me.
He's lost in space.
Yeah.
Well, actually, while we're at it, though, as long as everyone else can hear us, Vicki, I must say I appreciated that one first photo you had about the lack of contrast in staircases, and because
That was Paul's idea, but continue.
No, very good idea. Yeah, there we are, waiting for Jeff. Yeah, basically, it's another aspect actually of architectural consideration. All that when it comes to safety is lighting, simply. Because I've seen staircases where there's so much light blaring at you, you can barely see the stairs you're going towards or going down or whatever. Yep, there you go.
Yeah, no, it's a very important consideration. There's from what I'm aware of, at least the strongest evidence that I'm aware of is from New Zealand, and they actually did a study to show that good lighting will reduce the risk for falls and injuries.
Oh,
and I think that absolutely applies to staircases, both from a vision detection perspective, but also not blurring into your face. So I'm just looking at this question now. Do I know if the falls took place at the top, bottom, or anywhere along the staircase? We do not have this information in the data set I was working with. It's also hard. We don't have details on how many stairs are present. But we do know is that even, longer staircases, if you fall at the top, you've got a further way to go, but even short ones can present a high risk for injury. So,
yeah.
I'd like to make a comment, Richard. You're talking about music. Alzheimer's Society had a music program because they found out a while ago that people with Alzheimer's, dementia, cognitive problems, they respond to music. So they got together a plan, and they bought little mini iPods and loaded them up with music of whichever generation, language or whatever, and they gave it to a lot of people in long-term cares, and it really brightened up the place, because you'd be seeing people, instead of just sitting there, they'd be bopping with the music or even mouthing the words, but it brings them to life.
Yeah,
and that's what Alzheimer's Society does.
That's actually, I'm really glad you mentioned that, Paul, because, because I'm still a member, I think, of the BC Alzheimer's Society. So, I might even consider getting in touch and seeing what they think about, putting it together, something like the Sound Beam. Because once this pilot project is completely together at the care home here in Quebec City, I'd like to at least approach other care homes and see if they're interested.
I think that'd be a good thing.
So, thank you. Sorry, folks. My Wi-Fi had cut out there for a minute or two. Let's see where we're at here. I think we have a question here for Lynn. Would some measures be put in place to reduce the risk of older adults being taken advantage of?
That's a hard one. I know. I don't know if you have any insights, Betty, or anybody else on the panel. I don't know. See, again, where ours is just saying there are resources available. We're not really talking about how to identify at risk, but I think, Betty, your organization obviously has.
Yeah, in order to volunteer for Meals on Wheels, you have to have gone through the screening of criminal record check and social development, sector, all of those things. So I think that in terms of our pilot, this has been taken into consideration. I think at the end of the day, it depends where we land on exactly what will the connector do and what is effective. And then we may need to revisit this, Lynn. I think it's a very good question.
Absolutely. Yep.
Yeah.
Okay, panel, at this point, what I'd like to do, if it's okay with you, is just go around the virtual table and see if you have any kind of concluding thoughts or comments on issues relating to your presentation, things you may have heard or thought about and reacted to from the other presentations, any kind of concluding thoughts. And maybe we can start with, let's start with Betty. Any final thoughts for today, Betty, that you want to share?
It's just been excellent to listen to the other presenters as well as our own, and I've loved the questions. And it's thought-provoking, and it always tells you how important it is to have a network and to communicate with one another. And so thank you for the opportunity and a chance to to talk about what's exciting to us.
Mhm. Lynn?
I agree. I think these are always welcome opportunities to have others who, because we're so close to the project at this point, and so to have others kind of fresh eyes and tell us, you know, oh, have you thought about this? And certainly already I'm going off and doing some more reading. But I also actually really appreciated this group of presenters. I love how, you know, we're all working on these different aspects and yet how there are these parallels. So I'm really thankful to have been here today.
Mm-hmm.
Wonderful. Paul, how about you?
Yeah. First of all, I enjoyed this immensely, and I enjoyed about the Meals on Wheels because a friend of mine, she passed away a few months ago. She was a recipient of Meals on Wheels, and I mean, really professional people that deliver the food and everything else. And Richard, your music venture with the sounds, I think it's very creative, and that would get a lot of people in homes moving.
Mm-hmm.
And they'll just sit in the chair or sit in a wheelchair and watch the world go by. But it's activity. And also people who are diabetic, they have to exercise. And if they have cognitive issues, you know, stairs can be an issue.
Mm-hmm.
So thank you.
Mm-hmm. Vicki, how about you? Thanks, Paul. Vicki, how about you? Go ahead.
I don't know if I can summarize much more than everyone else said. I think that the breadth of this panel kind of reinforced just how broad the challenge of supportive homes and communities are, right? And really just how important it is to bring people from different backgrounds and different sectors and life experiences together to work toward this common goal. So yeah, I enjoyed all of the talks, and it was just a fun session, and as well as the questions from a very broad and engaged audience.
Excellent. Great. And Richard, I have a special reason for letting you have the final word, so to speak, and that is because I so admire your taste in polo shirts. I just want to make sure I got that plug in there.
The color especially.
We didn't plan this, by the way. We didn't plan this, but you know, we're kind of bookends for the session today. So anyway, go ahead, Richard.
Well, first off, I'm deeply inspired by what I've seen today. Like, it's just awesome being together with all of you. And Paul, I love your dartboard. But I'd like to end with that quote I mentioned because it applies so much to what we're talking about, especially the very serious concern of social isolation. And I can safely say also that this is the absolute driving factor behind my own project. So I'll leave you with this. Let me just read it out. And this is from that report I mentioned, okay? This pandemic has upended lives everywhere. However, for most, there is a post-pandemic world that will bring back the freedoms and choices we once took for granted. For residents of long-term care, however, this tomorrow may never come. Perhaps that is why we found that most residents of long-term care are not as worried about contracting COVID-19 as we might think. The comments we heard from hundreds of family members indicate there is a greater fear of death from loneliness. So, I know that's a pretty sobering quote, but basically to me, it just says it all. I mean,
it does.
Yeah.
It does. Appreciate that, Richard. Thanks so much. And I want to thank those of you in the audience, by the way, if you enjoyed the session, if you have some thoughts on how sessions like this can be improved, please feed those in either via the chat or offline through the EPIC conference website. And I'll just maybe ask Allison, our organizer, do you have any concluding comments or advice for us today on before we adjourn? Allison, are you there? Nothing. Oh, comment is nothing from us. So I think then we're good to go, everyone. Stay safe and keep up the great work. It's been a pleasure hosting this session today, spending this time with you all.
Likewise.
Bye-bye now.
Thanks very much.